Yep.
Cool. I don't know if you heard that, but yeah, recording in progress. So over
Yep.
to you, Jess.
Got it. Well, Selena, you're the only one in here with us, so hello. Thanks for joining. So today we're going to talk about what's happening at the hip and pelvis. So I'm Dr. Jessica Klain. I go by Jess. I am a physical therapist with my doctorate. I'm also a personal trainer, certified strength and conditioning. COMT, I am a certified manual therapist, OCS, orthopedic certified specialist, and CNPT, a certified nutritional physical therapist. So I do lots of different things. But today we're going to talk about the hip and pelvis. So I am educated solely in the United States, so very traditional track of bachelor's degree, graduate degree, lots of post-grad credentials that I did in the last 12 years. I've been practicing mostly in Colorado, a little bit in Alaska, and now I just recently started my own practice here in Denver, doing a lot of different things in the personal training, PT world, physical therapy world, and personal training world, and um, getting out with some running clubs and things like that. So we are going to cover a lot today, and I will give Leo a PDF of this whole presentation, so you can always come back and reference it. But we're going to go over specific anatomy variations to females and how that relates to the injuries that we most commonly see in females, and different things that we can look at when our client is in front of us, and then based on those movement screens, specific exercises that we can do to address those issues and perhaps reduce the chance of injury, or kind of help people get out of their injury phase by making some just basic, easy modifications once you know what you're looking for. So the bony anatomy of the pelvis and hip is actually very complicated. The pelvis itself is made up of 3 different bones. They do not move independently of each other. So all together, they form the pelvic ring with the right pelvis, the left pelvis, and then the sacrum and the back. So we have 3 joints of the pelvic ring, the right SI joint, the left SI joint, and then the pubic symphysis right in front. The pelvis, those 3 bones of the pelvis on the right and the left side, they form the acetabulum, which is the socket of what we consider the hip joint. And then you have the ball, the head of the femur that sits into the acetabulum, which forms that ball and socket joint of the hip joint. And then we also have variations of the femoral neck, the long part of the top part of the femur, and then that bony nub on the side, the greater trochanter. So usually when I have clients in front of me and they say, oh, my hip hurts, they point to the side of their hip and they're actually pointing to the greater trochanter, which is the femur. It's not the hip joint itself. Like when people truly have a hip joint issue, a ball and socket issue, the pain appears deep in the groin or deep in the glute. So if somebody says, I have hip pain, you always want to ask, where is that hip pain? Because there's a big difference in what we're going to do and what we're going to look at based on the location. So a lot of ligaments that help keep us stable in that pelvic ring and in the hip joint. The one that kind of I give the most attention to as a physical therapist is the sacroiliac ligament. So it is a really, really strong flat ligament that connects the sacrum to the pelvis on both the right and left side. Then you have a really strong ligament in the front where the pubic symphysis is, where the 2 pubic bones of the pelvis come together in the front. Sacrospinous ligament is also a pelvic ring stability ligament. And then the hip joint capsule, which is made up of several different ligaments, that gives a lot of support and stability to that ball and socket of the hip joint. So lots of muscles. I think of it in 2 different parts, kind of the upper part, which is going to be those muscles that start in the low back and then come into the pelvis. And then the bottom half is kind of the pelvis and then into the femur. So the Quadratus lumborum is kind of that sister muscle to the iliopsoas. It's the thick muscle that kind of sits behind the iliopsoas for our back support. And then you have the iliopsoas, which is a major hip flexor. And then muscles that get ignored a little bit are the piriformis and the hip external rotators. Those give your hip joint a lot of rotational support and has a lot to do with knee position that we'll talk about in a little bit. Glutes are obviously something that physical therapists and personal trainers focus a lot on. We want to make sure that we are getting all fibers of the glute need when we train. And that we have to pay a lot of attention to what degree of hip flexion our hip is in while we're training glute med to make sure that we're training it in the most functional way for our functional activities. Then adductors are a huge group of muscles. They play a big role in lower leg and knee support, but they are also very tied to your pelvic floor muscles. And so a lot of times when you have issues in the adductors, it's really a secondary issue from a pelvic floor issue. Then obviously quadriceps and hamstrings are big players of our thigh. And then I've already mentioned pelvic floor. We'll get into that a little bit deeper, but that is something that is a huge source of potential symptoms and dysfunction in female athletes of any kind, even if they've never had children before. So this is something that the physical therapy world is focusing a lot on. And there's a lot of things that weight training can do to help pelvic floor function, but there's a lot of things that weight training can do to really interfere with good pelvic floor function that then can interfere with quality of life issues. So other things that are going on in the hip is the labrum. So that is very similar to the meniscus in your knee. It is a almost circular, not quite circular, ring of cartilage that sits in the ball and socket that serves to cushion the joint, but it also serves to limit some of like the shearing forces that occur when you're doing certain motions, like specifically a twisting or pivoting, like playing soccer or golf or tennis. So the labrum is a major potential issue in females, and we'll talk a little bit more about why in a little bit. Sciatic nerve is always a hot topic. A lot of people come into my office and they say, oh, I have sciatica, and it's by true definition, it is not sciatica. It's more radiculopathy from the back. And that is just, it's a little bit of semantics based on the actual anatomy of what's going on. But your sciatic nerve doesn't actually start until your deep butt. And so usually that's not the origin of the symptoms, but it can be a common thing that people complain about. So learning kind of what people call it and then learning what it really is really helpful in determining what you're going to do about it. So I already mentioned greater trochanter being what a lot of people will point to as their hip pain, but usually if they're pointing to the outside of the hip on that bony protuberance, your greater trochanter of your femur, it's actually greater trochanteric bursitis, which can have a lot to do with what your IT band is doing and your TFL is doing and form. Greater trochanteric bursitis, way easier and simpler to address than true hip pain. So I always get a little relieved when people say they have hip pain and they're actually pointing to their greater trochanter and not their hip. So hip motion. So this might be a little different in Europe. We call it hip external and rotation and internal rotation. Sometimes it's called medial and lateral rotation. But these terms I will use later in our sessions. So just making sure that we're all on the same page of what motions that I'm talking about. And then pelvic motion is a huge thing for um, cueing how to move, how to hinge through some deadlifts, some squats, and how your pelvis moves is going to change a lot of the orientation of the acetabulum, the socket. So if we start getting a little kind of pinchy pain in the deep groin with certain movements, sometimes we just need to change the pelvic position just a little bit to alter the orientation of that socket through those motions to avoid that pinching pain or that compression through the labrum or the acetabulum. So that's kind of the basic, what are the different things that we're talking about? We're talking about, the bony anatomy, we're talking about ligamentous anatomy, the different muscles, and the different pelvic positions that all play a part in how we move. And the thing that's really important to point out is that a lot of times the right and left anatomy of a person, male or female, is different. So just because one movement on one side, if your foot's at a 30-degree out angle versus a 25-degree out angle, sometimes it has to be different side to side because of the shape of the acetabulum, how it's oriented, and the differences in the femur side to side. So some of these differences can be due to genetic differences. You're just born a little bit different, and maybe it's a millimeter, maybe it's 5 millimeters. But with repetitive activities like running and weightlifting, those little differences can rear their ugly heads in a variety of different ways. So we want to be aware that not only are we talking about differences male and female and then differences between females, but we're also talking about differences right versus left. And that can have a huge effect on what recommendations we're giving to people to solve some of their issues that they're having. Another component of training females that we don't have to deal with men is the changes in hormone levels with the menstruation cycle changes the flexibility of the collagen in some of those big stabilizer ligaments. So specifically the pubic symphysis ligament that connects the two pubic bones in the front, and then the long dorsal sacroiliac ligaments, those big strong ligaments that connect your pelvis to your sacrum to form your right and left SI joints. All of those are affected by the hormones during the menstrual cycle. And so what I commonly see is the first few days before the menstrual cycle is people will develop kind of like these deep aches in the SI joints or in the pubic symphysis because we're getting just a little extra motion there. And that creates that like achy pain because you feel unstable. There's some other kind of more intense symptoms that can be associated with it, like kind of popping out of place, which is really uncomfortable, and using different strategies to kind of get back in place and stay in place. But that pattern, once you recognize that you need to look for that pattern, it becomes really obvious, and then you develop strategies to implement prior to that the menstrual cycle to kind of help with that stability, so you don't get those deep achy pains or pinching pains associated with that pelvic ring instability. So kind of more on the pelvic ring itself. So little bit of physics here. It's a very different type of joint than the ball and socket. So the ball and socket of the hip joint, you get bony stability from the shapes of the bones. The pelvic ring itself is designed more as this force closure system, where if you pull one piece out of it, the whole thing's going to collapse. So the problem with that is when we get a little bit of instability during the menstrual cycle because of the collagen changes of the ligament, then then that whole thing starts moving around. Instead of, if you're having movement at one joint, like if you have pain at your right SI joint, it is affecting all of those other joints. You might not have pain there, but the ring itself has been disrupted and it can create issues at other points in that kinetic chain. The pelvic floor muscles that sit like a hammock on the bottom of the pelvic ring, those muscles will try to hang on for dear life to help try to stabilize the pelvis during that instability period. And then that's when you start having issues with like stress incontinence or deep pelvic pain, or sometimes it shows up as deep hip pain as well. So pain or soreness can be part of that pelvic ring or pelvic floor issue, along with some other like stress incontinence and urge incontinence issues as well. So the acetabulum, in terms of the differences in how the acetabulum will affect your hip motion, there's a lot of different variables with it. So the first one is the actual depth of the socket. So again, this can be different side to side, and it's certainly different person to person, and it's definitely different male versus female. So there's there is kind of perfect anatomy numbers, but nobody has perfect anatomy. So in general, you're going to err a little bit too deep or err a little bit too shallow. Both of them have issues. So if your socket is too deep, that means the overhang of the socket is too much for the ball, and then it's easier as you move for that ball to jam into the edge of the socket, and that's called pincer impingement. So the opposite of that is if the acetabulum, the socket, is too shallow, then think of it more as like a golf ball on a tee. Like a big gust of wind can just blow it off the tee, and just like the ball rolling off the tee, then you worry about the head of the femur wiggling around too much in the socket. It's hard for a hip to dislocate. It can, but usually what we see is labral pain, and like muscle pain, because it's trying to help stabilize the joint that's unstable. So when that's too shallow and we're getting those instability symptoms in the hip, then it's even more important to work on those hip rotators, those internal and external rotator muscles, to give that hip the stability that it needs. So something that you can do to test is you lay somebody down, you bring their hip up and you move it into hip internal and external rotation. Are they really stiff? Probably means that they have a deeper acetabulum. If they have tons of motion, it probably means that their socket is a little shallow, and you have to be aware that what they need is more strength, not flexibility. So that's the depth of the socket. Then there's the orientation. So the expected normal is for the socket to kind of sit anteriorly, inferiorly, and laterally. But there can be any slight variation of all three of those orientations. And so depending on how that is oriented, it is going to change how much your hip is going to move in certain directions. So I just talked about testing somebody for hip internal and external rotation in terms of total mobility to determine the depth of the socket or give some information on the depth of the socket. Now we're saying, like, is your hip internal rotation and external rotation equal? And if you have a little bit more internal rotation, that tells you that you have a little bit more anteversion, or it's more forwardly oriented, which is common in females, than the opposite. So that will play into effect in terms of, when we're squatting or deadlifting, how um, how we are encouraging people to put their feet in what's happening at their knees and what's happening at their hips. Because sometimes if we put people in what we think is the perfect form, they're going to end up grinding through their hip because they don't have the normal orientation of the acetabulum. And if we don't take that into account, then we're going to contribute to an injury at the labrum potentially. And so that is the most common hip injury in females at the acetabulum, is that labrum getting sheared or pinched or kind of smushed into the joint. And those injuries are tough. They can be non-surgical, but a lot of times they do end up being surgical because they interfere with quality of life. They interfere with sitting. They interfere with squatting. They interfere with bending down. And then in terms of like sports and activity, sometimes it'll be like a sharp catching pain when you're trying to run or lift heavy. So it's definitely something that we want to prevent happen, or if we know that there might be something going on with the labrum, what are things that we can do to help support the hip without aggravating the labrum more. So that was all on the socket. So that's the acetabulum, which is part of the pelvic ring. Now we're going to talk about the other bone of the hip joint, which is the femur. So we have a few different variations of what can happen at the femur that's going to affect motion at the hip. So the first one we're going to talk about is the angle of the femoral neck. So that's the angle of the short part of the femur in relationship to the long part of the femur. So normal angle in theory is about 120 degrees. If your angle is less, you are said to have coxa. If the angle is more than that, then it's coxa valga. Both of those changes are going to affect what's happening at your hip, and it's going to affect what happens at the knee as well. So at the hip, when you have coxa, you end up getting more pressure through the top part of the socket and the top part of the labrum. So we see a different pattern of labral tears when somebody has more coxa versus coxa valga. It changes the pressure and kind of the shearing forces at the labrum. Kind of minor. I would say more importantly, what we see as movement people is what's happening at the knee because of this femoral neck angle at the hip. So when we have that decreased femoral neck angle, the coxa, we see somebody be a little more knock-kneed, versus that coxa valga, we see people be a little bit more bow-legged. So females typically are going to be in that coxa, that decreased femoral neck angle. So we see a little bit more knock knees in women than we do in men. And there's other factors that go into that knock knee as well, which we'll cover. But if we see somebody going into knock knees, we need to know, is this a bony issue or is this a neuromuscular control issue? Because we need to address it very differently. If it's a bony thing and we don't recognize that, then we're going to force their knees into a different position, right? Which is going to affect what's happening at the hip, and the hip's not going to like that, and that can create issues at the hip. So sometimes it does make sense to say, hey, have you ever had an x-ray of your hip? Get a protractor out and measure it. It's that simple. So the other component that's going to affect how we move through our lower extremities with squats, deadlifts, and other functional things is femoral torsion. So with these pictures, we're looking down on the hip joint, and it's a matter of, is that femoral neck and head, is that angled forward or backwards? So we're looking at it in a totally different plane than the femoral neck angle. So usually we see in females an increase of femoral neck anteversion, which means that the, the neck of the femur causes the rotation through the length of the femur to cause the knee to go inward a little bit, also contributing to that knock need. And so this is another bony issue that we cannot change as physical therapists or personal trainers. We just need to recognize this is how you're built and what are we going to do to adjust for that, so we keep you safe and help reduce the potential of injury. So this is going to have a lot of importance on that rotational stability. So kind of coming back to that hip internal external rotation, how much motion do they have? And if they have a ton of motion in one way, we need to make sure that we are addressing the need for stability through that motion, so that the hip joint is supported with these variety of activities to reduce that shearing force through the ball and socket, protect the labrum, and protect the joint. So the pelvic floor. So this is a picture of looking down on the left and looking up on the right. So lots of different muscles make up the pelvic floor, and all of these muscles exist on the right and the left. So we have, almost a dozen different muscles that contribute to the pelvic floor function. And the pelvic floor has more than just the need to support the pelvic ring structure itself, but it actually is responsible for supporting organs. It's a major player in our sexual function, has a lot to do with how the diaphragm works with breathing, and it helps us pee and poop. And so if there is issues with the pelvic floor, we are going to have issues with peeing and pooping in a variety of different ways. So injuries commonly seen in females. So these are injuries that are typical based on the anatomy that we've looked at. So that doesn't mean that they can't happen in men. It's just that they are way more common in females because of the tendency for females, from our pelvic shape to our femur shape, and how that relates to movement patterns that we do. So I've already mentioned this many times, labral impingement. So part of this is going to be what's happening with the depth of the socket, the orientation of the socket, and then the orientation of the femoral neck and the torsion of the femoral neck. So all of those are variables that we can't change. But the things that we can change are how people are moving. So if we are suspicious that somebody has impingement at their hip, the last thing we want to do is give them exercises of repetitive flexion and rotation. Those are prime motions that stress the labrum. And if the labrum's already irritated, it's just going to irritate it over and over and over again and not let that labrum calm down and heal. So we have two main types of labral impingement. We have that pincer impingement, which happens a lot when that socket is really deep. And then we have cam impingement, which has more to do with the femoral neck shape. And we see the impingement occurring at the femoral neck instead of the socket. That's a little more detail than we probably need to get into. It does change the surgical options. But in terms of what we do as physical therapists and personal trainers, it doesn't really change because we're still going to avoid that repetitive flexion and rotation. With both pincer and cam impingement, patients are going to complain of that deep groin pain and perhaps like a pinching or a catching or a clicking sensation with that hip flexion, so deep bend, and that internal rotation, turning our foot inward. Other things that I hear a lot are like a deep butt pain with prolonged sitting, especially if you're sitting in the car or on a couch, and just the a general like achy discomfort when you do a lot of loaded activities like lifting heavy. So another one that I've already mentioned a little bit is the SI joint pain. This is a big topic in the physical therapy world, and it's something that I treat very often. Usually, when I see SI joint pain, I'm also seeing some lumbar pain as well as hip pain. They're all very closely related to each other. So, when one isn't moving well, it will affect the other one. And, in general, our body is going to take movement at the path of least resistance. So especially if we're close to our menstrual cycles, we have those hormonal effects that affect the collagen. Um, Perhaps the SI joint is the path of least resistance for movement, and that creates some unequal forces through our pelvis, which can very much flare up an SI joint and make life a little annoying. Um, so usually when somebody complains of that SI joint pain, it's one-sided, so it's not right in the center, and it's kind of right in that like upper glute, like definitely below your low back, and then you end up with some glute med soreness because your glute med is trying to help stabilize the SI joint, and it just does a bad job of it. The thing that's going to make SI joint pain worse is unilateral exercises because it will create unequal forces through one side of your pelvis, creating increased forces through that SI joint. So, single leg squats, lunges, running, those are things you just, especially like single leg plyometrics are another big one that can create irritation at the SI joint for somebody who is having hints of SI joint pain. The exercises that are better to choose are bilateral exercises. So bilateral squats, planks, deadlifts, anything where your right and left leg are doing exactly the same thing. Other things that we can do to help that is kind of creating some stability through the thoracolumbar fascia, which it forms between the right lat and the left glute and vice versa. So the more kind of glute and lat stuff we do together, it strengthens that thoracolumbar fascia, which crosses the SI joint and helps give a lot of stability to the pelvis in that way. So pelvic floor injuries. So we can injure the pelvic floor through pregnancy, childbirth, even a chronic cough or regularly kind of bearing down. And then just as we get older, if we gain weight, it's going to really affect how that pelvic floor functions. So when we have true weakness of the pelvic floor, like the pelvic floor muscles aren't activating properly, they don't have the neuromuscular control because they're kind of out of shape, or because they've been injured through a variety of different ways. One of the main symptoms is just leakage. So it could be stress incontinence, it could be urge incontinence, but the problem is weakness. And so therefore we want to strengthen them through Kegels. Now, Kegels, I think pretty much everybody's familiar with them, but they are a very, very specific exercise. And just tightening your pelvic floor to stop the flow of urine is not the right type of Kegel. I will find a really good YouTube video and give it to Leo so he can post it. But there's a very specific way to do proper Kegels that have to do with breathing and using your diaphragm and lifting and relaxing, that is much more complicated than just tightening. But more commonly, what we see in young people, especially if they haven't had babies yet, but active people, so runners and weightlifters, is the problem is not weakness. It's hypertonic tight muscles. And when muscles are tight, they cannot function properly. And so if they're already tight and you do Kegels, then you're contributing to the tightness, you're contributing to the problem and not going to solve a single thing. So we get tight muscles because of pelvic ring instability, so SI joint issues, pubic symphysis issues, especially around our menstrual cycle, stress and anxiety, irritable bowel syndrome, STDs, pelvic inflammatory disorders. So a lot of these things that can be underlying issues that maybe go a long time without being diagnosed can contribute to a pelvic floor issue. And if we don't address the pelvic floor issue, it does not get better. It just keeps in their bad habits and keeps interfering with your life. And it drives me crazy when I see commercials for like, oh, just use a pad for your leakage. Like, okay, yes, that's better than peeing your pants, but it's kind of assuming that everybody has leakage and it's okay. Let's not solve the problem. Like there are a lot of things that we can do to solve the problem of hypertonic pelvic floor issues. We just need to know what the symptoms are and what to do about it. So weakness is just kind of general leakage, maybe a lot, maybe a little, but the hypertonic pelvic floor issues are more of this sudden urgency. Like all of a sudden you go from like 0 to 10 and you can't hold it, and like you leak before you get to the bathroom because your sphincter muscles cannot function well in a neuromuscular way to prevent you from leaking. It's also very frequent urination. So if you're using the bathroom more frequently than about 2 to 3 hours a day, then we kind of have to worry about what's going on with your pelvic floor muscles. Constipation is another common one. And then kind of deep glute pain or deep hip pain is another sign of hypertonic pelvic floor muscles. So the exercises are totally different than Kegel because we don't want to strengthen them. We don't want to overactivate them. We want to relax them and retrain them how to work again. So it takes a lot of self-awareness, and sometimes it means going to a pelvic health physical therapist for them to do an internal exam and teach you how to do a pelvic floor activation with breathing in the proper way. That's becoming a more common thing in the US. I'm not quite sure what's going on in Europe, but usually Europe is a little bit ahead of America in the physical therapy world. So I'm sure there are specialists there that help with that. So that kind of covers the differences in anatomy, the common injuries that we see, but now what do we look for when somebody's right in front of us? So one of these is just a basic squat. So I am sure you guys have covered a lot of this type of thing in your personal training education in terms of what are we looking for. But I want to go one step further and say, what are we looking for? And then what are we going to do about it? Or why is that happening? Is it because they're new to this and they don't know how to do it? Or is it because there's a labral issue, because one acetabulum is different, because one femur is different? We need to know a little bit more of why this movement pattern is happening. So the things that I ask people are, what is the limiting factor? Is it tightness in your glutes? Is it deep pain in your groin? Is it catching? Is it stabbing? Do you think it feels good? All of those things. But if we have a labral issue, the tendency is to shift away from that painful side because they're trying to limit the amount of hip flexion in that squat. And so if all we do is say, well, you need to shift your hips backwards, let me put you in front of a mirror, then we're actually going to contribute to the labral problem and, perhaps give that mentality of you just need to push through it, which is usually not the case when we have an anatomical issue. So another component of the bilateral squat is, where are your feet? So are they turned out into external rotation? Are they more neutral? Are you in more abduction? Or your feet closer together? All of these things are going to change how the head of the femur moves in that socket and what type of forces are going to occur through the labrum and through the joint, but also how different muscles are going to react. So whenever I have somebody that, maybe they don't have pain in the deep squat, but they're like, that feels weird, or I don't like that, I will always just mess with their foot position. I say, does that feel better? Does that feel normal? Does that feel good? Does that feel bad? And just kind of figure out what is their best position, and that's where we start. Because if their joints are not comfortable in the way that they're moving, then maybe it creates pain that first rep, or maybe it doesn't create pain until that 100th rep or that 1000th rep. Either way, we want to encourage the joint to move in its best way possible. And a lot of times that means taking the time to figure out where their form is best, not what our textbooks told us was our best form. So then going into single leg squat, you can almost always find an issue with the single leg squat. So you want to look at the shoulder position, the pelvis position, and the knee position. So this will be affected by anatomy, but now we're also really looking at what's happening with that glute strength and activation on that stance leg. So the bilateral squat is going to tell me a little bit more about anatomy. The single leg squat is going to tell me a little bit more about that neuromuscular control and how strong and how active are those muscles that are controlling the pelvis, the hip, the knee with dynamic movements. So this top one, we were looking more at the trunk and what's happening. And then we want to also look at what's happening at the pelvis. And we also want to look at what's happening at the knee. So that knee caving in, is that an anatomical thing, or is that a neuromuscular thing? And so usually the question is I will force the person to keep their knee straight, and I'll ask them, like, is that harder in your glutes or is that easier? Does that create pain? Does that feel weird? Can you do it? Can you go as far? And so how you look at this and how you fix this and the questions you ask gives you the information of, is this an anatomical thing, or is this a neuromuscular thing, or is it a little bit of both? But we need to put those puzzle pieces together. So the other thing that's very common is avoiding the movement at end range. So this is people in a bilateral squat that shift away from the painful side, or maybe they just don't go as deep. And then the question is, well, is it because you're stiff? Is it because of pain? Like, what do you feel? Why can't you go deeper? For runners, it's running with a shortened stride on one side, which will create a host of problems down the road. And then with bikers, changing their seat positions, changing their anatomy, or changing their anatomical position by changing their bike can do a lot to kind of protect hip joints. And that's a whole other topic of how much do you change the bike versus how much do you do to change your movement patterns to fit on the bike. So with pelvic floor, we need to be aware of how we are breathing during our activities. If you are suspicious of somebody having a chronic pelvic floor issue, if you look at their rib cage, their bottom rib cage, and you see a flare of the ribs, I almost guarantee that they have a pelvic floor issue, because the ribs flare when we have a long-term change in how we breathe. It changes how the diaphragm works, and if the diaphragm is not working the way that it's supposed to, then your pelvic floor is not working the way it's supposed to either. Another compensation pattern related to that rib flare is hinging into extension, into like a thoracolumbar extension on a deep inhale to get that space for your lungs to expand versus just expanding through your rib cage to get the air in. So things that we can do for our clients to help them move better. This is always my first line of defense, is creating the stability of your hip through hip internal and external rotators. So if all we are doing is big weightlifting, like bench, deadlift, squats, we are not getting these stability muscles that give that joint the support it needs through the squat, especially if we're going into like full range deep squats. These hip internal external rotator muscles are the things that keep the labrum and keep the bony surfaces happy in those deep positions. So variations in sitting, laying on your side, laying on your stomach. You can use light therabands and do high reps. You can use heavy therabands and do 3 sets of 5. It doesn't matter. It just has to be done. And you have to be careful of compensations, because there's a lot of ways that you can kind of cheat through these exercises, which is even more of an indication that these exercises need to be done because they're weak, and that's why you're compensating. So hip abduction, so a lot of glute med, a little bit of glute minimus and tensor fascia lata. Again, all positions, right? Side, standing, hands and knees, using therabands, using body weight. It is strengthening, but it really is more of a neuromuscular activation. Can we get these muscles to fire in the way that we need to help us have better form in the activities that we want to do? So core is a big one. And as a physical therapist, when I talk about core, I'm almost always talking about the transverse abdominis, which is a deep core muscle that looks and acts like a girdle. It attaches to every single vertebrae in your spine. So when it is active, your spine is stable. When it is not active, we have some movement pattern problems. The way we train that is very different than how we think of normal core activities like sit-ups and planks and crunches and all of that. So we want to make sure that we're capturing both sets of these. And so the transverse abdominis activation is very similar to how we activate pelvic floor. It's more of a, is it on, is it off, versus, oh, my transverse abdominis is so strong. It is more of a neuromuscular control than it is getting stronger. So I'll find another YouTube video that I can give Leo the link for, to kind of work through some of those breathing patterns for pelvic floor and transverse abdominis. So I've already mentioned, especially for that SI joint, how important bilateral exercises are, specifically through the lats, the glutes, and the adductors. So this helps us with pelvic ring stability. It also helps with that thoracolumbar fascia external support system through our low back and through our pelvis and through our hips. So again, a lot of different variations of how we can activate this. I mean, you can be as creative as you want to with these. These are kind of some of the basics, because we don't want it to be about like how difficult the form is. We want to be, are you activating your glutes? Are you activating your lats? And are we targeting what we want to with it? So yep, lats and glutes and the thoracolumbar fascia strength to give that stability. My first exercise is always rows and always lat pull downs. I just think bang for your buck. Give somebody a TheraBand to go home with and say, you need to do 1,000 of these a day, because the more regular force we have through the lats to tug and pull on that thoracolumbar fascia, the stronger it gets and the more support and stability that we have through that posterior chain. So I mentioned breathing several times, but specifically how breathing affects the diaphragm and the pelvic floor is like a piston. So when you breathe in, your lungs fill, your diaphragm goes down, your pelvic floor should lengthen and relax. And so then when you inhale, the air goes out, your diaphragm goes up, your pelvic floor should contract and come up. So in theory, your diaphragm and your pelvic floor, they are always moving in the same exact manner. But if your pelvic floor is always tight and your diaphragm moves in and out, then we have some issues with the abdominal cavity and kind of pressure through there. That's when you can have some issues with low back pain is a common one, and like hernias. They can also rear their ugly heads when our diaphragm and our pelvic floor aren't working properly together. But I think initially we had a whole nother class covered that we were going to do on breathing. I don't know if we're still planning that, but breathing is extremely important, not just kind of in while you're lifting, but in terms of retraining how your diaphragm and your pelvic floor are working on a day-to-day basis, and using those strategies for daily life, but also implementing them and choosing when to use kind of the bearing down or Valsalva maneuver, and making sure that that doesn't disrupt pelvic floor function. So that was a lot of things to talk about. The other things that we need to consider are leg length discrepancy. So that's just another anatomical difference that we can't do anything about in terms of changing the structure of that person, but maybe that means putting in a little heel lift on one side. And there's a lot of debate. If you got 10 people in the room, they would have 10 different opinions on this. Before I put a shim in anybody's shoe, I do a lot of other things, like lots of different soft tissue work, lots of different strengthening work. And if it's still a problem, then I say, ooh, we're going to try the littlest of shims and see what you think. Sometimes people come to me and they say, I had knee surgery and my surgeon told me I have a 2 centimeter difference and we need to put a heel lift in. I said, okay, sure, but let's start slow and figure it out. Surgical history, it is pretty common for females in their mid 30s to mid 40s to, if they have labral issues, that is usually when I'm seeing the surgeries be performed. Sometimes that means just stitching the labrum back in place. Sometimes that means shaving down part of the socket. Sometimes that means shaving down part of the head of the femur. Sometimes that's all of the above, which can help with the anatomical issues that they're having. But you also have to think about the disruption of the surgery itself. They're even if they do it arthroscopically, where they're not making a big incision, those tools are still big and they're going through the ligaments and through the muscles and cutting things away. It will change how they move. And if they were a big weightlifter beforehand, we need to kind of reestablish movement patterns post-surgery. And so that's true for a hip labral repair. That's also true if somebody has an ACL or a meniscus repair or I don't know if you guys are seeing people old enough to have total knee replacements or total hip replacements, but post surgery, the anatomy is different. And if we pretend like it's not different, then we could be contributing to another issue in the future. And since we are talking about females specifically, pregnancy and childbirth can have a huge, huge effect in um, um, how you're able to activate through your transverse abdominis and core. And a lot of that will depend on if they've had a C-section or not. And I always ask, was it an emergency C-section or was it planned? Because the amount of disruption in an emergency C-section is substantially more and takes a lot more for the muscles and the fascia to recover from. And even if they never had a child that came to term, sometimes those changes in hormones are enough to change some of the ligamentous integrity as well. So we do have to ask some specific questions on how many kids, what type of delivery, and specifically was it an emergency C-section versus a planned C-section, and then kind of what are your symptoms afterwards. And just because all of your friends might have the same symptoms does not mean that it's normal, and it does not mean that you have to suffer through peeing yourself every day or not going for runs because you're worried about peeing yourself. So getting into that can give a lot of information on how the pelvic floor is functioning, what's happening through that pelvic ring, and how is that going to affect how we prescribe movement patterns and exercises for the support muscles, but also for those big mover muscles. So take home message, there is a lot going on at the hip and pelvis. There are so many different variations that can occur at so many different places. And so it's different person to person, and then it can be different side to side as well. And so based on that, we cannot say, oh, your knee always has to be in line with your second toe, or your feet should always be turned out, or your feet should always be wider than your hands. You know, those are good places to start, but we have to have the knowledge to know, oh, let's wiggle this a little bit this way, let's try this. How does that feel? How do you move? Is that a better movement pattern that we can lift heavy in, so you can protect your joints but also achieve your goals at the same time. And then third take home message is Kegels are not always the answer to pelvic floor dysfunction. I'm going to go one step further and say they are usually not the answer. And if they are, there is a lot of care for them to be done in the proper way to actually address what needs to happen. So I am an open book. Any questions about this or how it relates? You can find me on Instagram. You can email me. You can ask me right now. Go on my website. Right now, I am doing physical therapy and personal training. Most of my personal training is more people who have graduated from physical therapy and they are not quite ready to go out on their own, because there can be a really big gap in the, you're not acutely injured but you still don't have kind of the knowledge to go out on your own to exercise. So I help people bridge that gap and help empower them to learn what they need to about their own bodies so they can make good decisions in the future. So any questions from you two on here right now, or should I just leave it to the recording?
Hi Jess, so the only question that I was going to ask you was just about how you'd be able to tell the difference between the pelvic floor being tight and then it being weak, but you went over that. So yeah, that was really interesting. I really didn't know about that.
Yeah.
But yeah, you went over that. So yeah, not
So,
really got
and
any
kind of
questions.
to extrapolate on that is it's interesting to me when I ask the right questions, how much good information I can get. But if I just say, hey, tell me, how has it been since you've had your kid 6 months ago? any leakage? And they'll be like, no. But then if I like ask specifically, like, have you ever leaked before? Yes or no? How often? You know, because there's, especially in the States, there's this common knowledge that women who have babies leak. And so everybody just assumes that it's normal. And it's not. It's common, but it's not normal. And so if they don't know that there's something that we can do about it, then they don't necessarily know the things that they should be telling you. So my recommendation is always to just get really specific with your questions. And I think maybe in the beginning of my career, I was like, I don't want to talk about people peeing and pooping. Like, I don't want to talk about their sex life, right? But it is a huge quality of life thing that even if you can't help them 100% with it, you can kind of help get that ball rolling of being like, hey, you don't have to live with this. I mean, I've had people that are like, I haven't had sex in 6 years because it hurts. And I'm like, well, what are you doing about it? They're like, nothing. Like, well, that's a quality of life thing that maybe I can't solve everything for them, but I can at least start like, okay, like what are your other symptoms? And here are some breathing things to get started with. And then let me hook you up with a provider that can kind of go more in depth with that. And then it kind of comes back around and they're like, oh, now I can lift without this deep butt pain that I thought was my glutes, and I've been theragunning it and it hasn't been helping. Well, that's because it wasn't your glutes, it was actually your pelvic floor, and we've addressed that and didn't even know that that was part of it, type of thing.
Yeah. I actually have a client that so basically from the front to the back completely ripped during pregnancy. So like she leaks like a lot of the time. And like so obviously I had said to her to try doing kegels and things, but obviously you're saying that there is a very specific way, so it'd probably be good to get that video to show her like that there is a more specific way to be doing it, and is she doing it right?
Yeah, I will definitely find a couple different options. And I don't know if Leo, I have the ability to just post it in the Facebook group, but if not, I'll just send you the link and let you post it.
Yeah, just post them straight in if you're happy to. You're more than welcome to send them to me first, but if you're happy to, then obviously you can put whatever caption you want with them. So yeah, anyone can post in the group. So yeah, please feel free to. And if you're happy to take questions in the group instead of like via your email address, then that would be amazing, Jess, if you're happy to, just because then everyone sees the question and benefits from the answer. But also then if you'd rather do a video reply, then you can obviously literally comment up to a 1-minute video. So if that's easier for you, instead of just typing out the answer, you might want to just do that as you walk in, then you can just do like up to a 1-minute video reply and paste that in the comments, or obviously film a slightly longer video if you would rather answer it that way and just post that in the group, which might be easier for you rather than email replying to people's questions anyway.
Yeah, I'm good with whatever. However, people want to ask me questions, I will answer them in the same way that they are asked.
Right, thank you, Jess. Yeah, ask them in the group then, people, so the group gets more active.
Cool. So Selena, I look for, I mean, it's midday for me now. I will have those videos up in the group by the end of today, but so maybe tomorrow morning for you, you can look at those.
Sure, that's great. Thanks, Jess.
Hi, Jess.
Anything else?
I have one question. I have my client, what she have that leaking problem. She is young girl, but she is playing like football, and she have 2 children. She been ready on by specialists, what they was doing treatment everything, but it didn't help her. Like she is still in bad condition, I can say, and she did everything for it. Do you think there are still some special exercises, different kind, how we can help her?
Well, I mean, if she's been to a specialist and they didn't help her, my first suggestion would be to find a different specialist, because there should always be something, right? If somebody's truly trained in pelvic health, then there's always something. Like you can take a non-symptomatic person and have them have a full evaluation by a pelvic health specialist, and there's always something that can be better. So without knowing exactly what they did and didn't do, I mean, in this sucks because she spent so much time and effort through that whole process. Is you kind of almost have to go back to the beginning and kind of reestablish like what is the main problem? What is the root cause of it? And then come away with some different ideas. So, the biggest thing with pelvic floor, the question is always, well, is it true weakness or is it hypertonicity? And sometimes those can be a little bit hard to determine, but the devil's in the detail with that. It's so maybe I'll put together like a questionnaire of like, if these answers are these, then it fits more with weakness, and if these are the symptoms, then it fits more with hypertonicity. And then, approaching a few different approaches for that. But we have to know that root cause. And I would, some of the like pregnancy, C-section, childbirth things, those are just questions that help us determine what category they fit in, right? It really, they can be split evenly. Just because you've had a baby doesn't mean your pelvic floor is weak, and just because you haven't had a baby doesn't mean that isn't possible either. So those questions are part of the information gathering, but we can't automatically put people in categories just based on the fact that they've had babies. So why don't I'll put together that, and then you can review that with your client, and then if you need some help kind of figuring out, okay, next steps, then get with me and we'll kind of figure out what her answers, what category we put her in, and what direction that she needs to go.
Yes.
But what I find sometimes when people have failed pelvic therapy is it's because they didn't stay at that foundational level of like breathing and diaphragm work and maybe some myofascial work long enough, and then they just try to rush into doing too much too fast. And it doesn't mean that when you're at the foundational level, you can be retraining your pelvic floor, and you can still be running, and you can still be weightlifting, and you can still be doing everything. But if you don't retrain the system correctly, and sometimes it can take 6 weeks, sometimes it can take 12 weeks. I mean, sometimes it's like, for me, I have issues because I'm training for a marathon. So I know that I have to spend more time with like yoga and stretching and breathing and fascial work, because if I don't stay on top of it, I will definitely have issues because I have an uneven stride length because of an ACL surgery. So it's like recognizing those patterns of, this isn't a problem if I'm not working out regularly, but it is a problem if I'm going to train for a fitness competition. And if we don't kind of have this whole separate category of breathing and stretching and kind of the boring stuff, then some of those pelvic floor issues are going to rear their ugly heads.
Yes, we have. Thank you.
You're welcome.
Awesome.
Anything else?
I will post a few exercises in the group if anyone's struggling to visualize what training the opposite lat and opposite glute together at the same time looks like for the thoracolumbar fascia. And I'll post a few videos in the group because that one might be a bit hard to visualize. But yeah, awesome. Thank you very much, Jess.
Okay, great.
Cool. We'll see you in
See you
2
guys
weeks
in
for the
3
foot and
weeks.
the ankle.
Yeah.
2 weeks,
Perfect.
3 weeks, whenever it was. And I'll put that poll in the group if people want the time changed slightly.
Yep, sounds
Awesome.
good.
Thank you so
Okay.
much, Jess. Have a lovely day.
Thanks,
And I'll chat to
everyone.
you
Thank
soon.
you.
Thank you very much.
Welcome.